Sorry for that.
That's okay. The most frequently cited provider type there is physicians and hospitals and nursing facilities for the minimum fee schedules. Although most states report minimum fee schedules tied to their Medicaid fee-for-service rates, a few states mention developing alternative fee schedules or using Medicare rates. Expansion of risk-based managed care has been accompanied by a greater attention to measuring quality and outcomes. In this 2021 KFF annual survey, over 3/4 of responding MCO states reported using at least one financial incentive, they're listed there on the left-hand side of the screen, to promote quality of care in a specified performance area. And these are quality incentives for plans. Financial incentive performance areas most frequently targeted by states include behavioral health, so mental health and substance use disorder, chronic disease, and perinatal and birth outcomes. These focus areas are not surprising given the chronic physical and behavioral health needs of Medicaid enrollees and given the significant share of births covered by Medicaid. Just as states have been focused on quality incentives for plans, states are also focused on moving the needle at the provider level. States generally pay plans a capitation payment, but plans have wide latitude to determine how to pay contracted providers, and many may pay on a fee-for-service, capitation, or other basis. As part of managed care plan contract requirements, state Medicaid programs have been focused on the use of alternative payment models to reimburse providers and to incentivize quality. These APMs lie on a continuum from those that involve limited or little risk for providers to those that involve greater financial risk for providers. So from these pay for performance kind of quality incentive payments to more risk-based payments for providers like shared savings and risk arrangements or capitation type payments. As of July 2021, more than half of responding MCO states identified a specific target in their MCO contracts for the percentage of provider payments or plan members MCOs had to cover using these alternative payment models. States may also include other requirements in their contracts with plans which direct plans to develop or participate in state-led value-based payment initiatives. So initiatives like accountable care organizations or episodes of care. Many states are leveraging MCO contracts to promote strategies to address the social determinants of health. Social determinants of health include factors like employment, education, and socioeconomic status. In our 2021 KFF survey of Medicaid directors, the vast majority of responding MCO states reported leveraging Medicaid contracts to promote at least one strategy to address the social determinants of health. More than half of states reported requiring MCOs to screen for behavioral health and other social needs, to provide referrals to social services, or to partner with community-based organizations. I've covered a lot of ground in a short time and stayed pretty high level today, highlighting enrollment, spending trends, and plan characteristics, as well as contract requirements, mostly focused on improving quality and value. To wrap up, I just wanted to highlight states have considerable flexibility in operationalizing their Medicaid programs within federal requirements. Over time, states have become much more sophisticated in their contracting with MCOs. States face many decision points and considerations with respect to implementing managed care models or transitioning populations to managed care, including beneficiary protections, considering the impact on safety net providers, including implications for moving from fee-for-service to managed care for supplemental Medicaid payments, rate setting and risk mitigation for the state and plans, just to name a few. My presentation hasn't been focused on the pandemic or public health emergency. However, I just wanted to note, looking ahead, plans will likely play an important role in assisting Medicaid agencies with the public health emergency unwinding, which may help improve coverage retention after the PHE ends. That concludes my portion of the talk today. I look forward to hearing about North Carolina's transition, and I'd be happy to take questions now or later in the talk.
We'll take questions later, and thank you. And we'll bring in Jay now. ahead, Jay.
Let me start to share my screen as well. Share screen. All right, sorry about this, just a second. All right, let me put it in presentation mode. All right, can you see that?
Yes.
All right, good deal. Well, good morning, everybody. I hope you are well. My name is Jay Ludlam. I am the Assistant Secretary for Medicaid here in North Carolina. I've been with the North Carolina Medicaid program for almost 5 years now, and helping North Carolina transition from a predominantly fee-for-service program to managed care. And so what I'll do is I've only got a very small handful of slides, but happy to take questions or direct things based on your feedback. But effectively, back in 2015, the North Carolina legislature decided that we should, as a Medicaid program, move to managed care. And it took us a little while to plan. And then we had an election, which took us in a slightly different direction. And then we were about ready to launch, and then we had some budget issues, and then we were we decided to put things on hold, and then we had the pandemic, and the budget issues got resolved, and we ended up launching in July of 21. So it's been quite a path, but part of the recent path that we have been on really has been dictated by this vision for our managed care program. And if you understand this vision, you really understand a lot of where our priorities and emphasis were in developing a new program. And before we moved to at-risk at-risk managed care, we did have a hybrid model where we had behavioral health, PIPs, PHIPs, running the behavioral health networks. We had a PCCM organization running the physical health network, and really never the two should meet. And so part of what the legislature was looking to do was to create an integrated care model and budget predictability, though not financial savings. That's an interesting asterisk on things, but really the enabling legislation focused on budget predictability and integrated care. So as part of the current governor's administration, when he took over the program, this is the vision he put in place. And it really is to improve the health of North Carolinians through an innovative, whole person centered and well-coordinated system of care that addresses both the medical and non-medical drivers of health. And again, there are a number of concepts embedded in this statement that allow for staff, providers, hospitals, managed care organizations to really understand the direction that we were headed with our program. Innovation, we were looking to hire the managed care companies to bring innovation, new thinking to our Medicaid program that might not be necessarily, was not considered a priority for the fee-for-service program. Whole person-centered care, this was in large part to address the issues of the bifurcated accountability, both financial as well as clinical accountability, when you have behavioral health taken care of by one system of care and physical health taken care of by another system of care. And so really a large part of what we were trying to accomplish in a move to managed care is to create one set of accountabilities, both clinically as well as financially. Well coordinated is in large part a nod to care management, and in our case, we implemented a localized care management program in the field, leveraging the strengths of our providers and the closeness that they have to their beneficiaries and the patients that they serve, and try to move that well-coordinated system of care out of the hands of necessarily us or those managed care organizations. It is also a nod to the fact that a lot of our work in going forward involves data, and the importance of being sure that we're contemplating really an ecosystem of providers, enablers who acquire information, are able to feed it to the organizations that can respond to it and best help the beneficiary. The medical and non-medical drivers of health, as part of our vision and goal that I don't know if we'll have time to talk about, but is a hallmark of our program, which is healthy opportunities, or addressing the social determinants of health that influence the health outcomes of our beneficiaries. And so this has been the vision that we've really guided ourselves with, and we can talk about it more. This is a little bit breaking down some of these concepts, and I apologize if this comes across your screen a little small. On mine, it's huge because I have a big monitor because I need glasses. But and I've talked about some of this, but some of it is around whole person care. We really had in our previous models a lot of trouble as an organization, as a Medicaid organization, holding others accountable for the services that they were providing, especially when there's an intersection of potential behavioral health or substance use disorder issues or physical health. And a great example is diabetes. We had physical health providers that would monitor very closely the glucose levels of individuals, but not be accountable for their substance use disorder of the beneficiary, the potential alcoholism. And so physical health providers might say, well, if not for our ability to control some of the behavioral health or substance use disorders, we can't move the needle and improve health for the physical health of our beneficiaries. Similarly, we had misalignment on the behavioral health and substance use side, which said, we're doing a great job handling the mental health or behavioral health issues, but not the physical health. We have no control over this. And so a goal of ours was to create a whole person centered system of care. And so as part of our design, we did make the managed care organizations accountable for both the behavioral health and the substance substance use disorders, as well as physical health. We also implement a concept here of buying health. And so this is buying health in whatever form it takes, meaning of course, we would reimburse for emergency room visits. If somebody breaks their arm, you're going to pay for that service. Of course, you would begin to move upstream and look at preventive health care. So working on well child visits, trying to address issues before they become really chronic health issues. But in a buying health model, you would also allows you to incorporate those community impacts around social determinants of health. And so this concept of buying health, in whatever form that takes, as long as you're improving the health of North Carolinians, we're really all in. We're interested in what you've got, what you're going to present. And so this is part of our model and allows us to incorporate addressing social determinants, preventive health care, as well as responding to the immediate, the crisis at hand, including, of course, when this was all designed in 2017 and 18 and 19, before the pandemic, buying health now starts, we're trying to figure out how do we incorporate public health concepts in addition to social determinants. Local care management, I've touched on this a little bit. That's putting the as much control over the health and improving the health in the hands of the community, in the hands of the provider serving the beneficiary, and really trying to empower the local care management. Our additional focus was on the member experience. So one idea here, and part of the information that is not immediately available or apparent in a move to managed care, but you start to create some distance between the accountable party, which is from our perspective at North Carolina Medicaid, is always the North Carolina Medicaid program. But when you insert a third party in between the managed care, the Medicaid agency and the beneficiary, and you started to insert a managed care organization, there is a concern that the Medicaid beneficiary themselves becomes disconnected. And so we wanted to make sure that we had a real eye on and an intentional focus on the member experience, and making sure that, for example, on day one, that they were able to reach a call center representative, that they were able to get an appointment for their condition, and that they had access to the mechanisms that can resolve the problems that they might have in a system as complex as managed care. And so that's been something that we've been very focused on, and actually is one of the key principles that guides our continued maturity and design around managed care. Of course, a key component of any Medicaid managed care or any Medicaid program generally is provider access. This is especially acute and critical as we exit the pandemic. Those are fingers crossed. As we exit the pandemic, just making sure that we have sufficient access to providers. I see, there are a lot of complexities with Medicaid managed care. I see one of the opportunities is the ability to use data to measure the ability of managed care organizations to innovate, especially around provider access, potentially to pay higher rates, to attract specialty providers or other providers that may not normally participate in Medicaid, and to bring them into the fold. And so I see network adequacy, which is a measure that, while done in the fee-for-service program through an access report that CMS does require, that the network adequacy component of managed care does provide a forum for the broad conversation about what are our health and public policy priorities. We have found in North Carolina, for example, that we have 98,000 providers in participating in Medicaid, enrolled in Medicaid, and yet we often talk about a crisis in access. And so why is that? What is going on here? What's the disconnect? And oftentimes the disconnect is really the way that those providers are spread out across the state, and also the fact that we allow for certain areas of our state in North Carolina, especially around the coastal area or in the mountains, in the rural areas of the mountains, where you just simply don't have broad participation with providers. You have very small rural areas, very small in terms of rural population. And so you're able to create accountability measures for managed care companies. You're able to use liquidated damages and other efforts, as well as to incentivize and create programs that incentivize the managed care companies to increase provider access. So you have tools to utilize, though I have to admit it's quite challenging to get these large organizations to write your contract language with enough specificity that you can hold them accountable in exactly the way that you need to in order for them to make those necessary investments. But it really, managed care is a platform that allows you to very accurately and carefully measure provider access, and to be sure that you've got those providers available to serve the beneficiaries and the conditions that they have. All right. So in July of 21, as we've already talked about, we moved approximately 1.6 million individuals. At the time, we had approximately 2.5 total Medicaid beneficiaries. That's in our full as well as partial benefit programs. We now have about 1.725 million individuals in Medicaid managed care and about 2.7 million beneficiaries since our go live in the last 10 months. So we continue to add a large number of individuals each month to our program. And as if you're tracking the public health emergency, you do know that CMS has put a condition of an enhanced public health emergency rate that we are unable to terminate Medicaid beneficiaries from the program. So we add people every month, and we take without really nobody unless you pass or move from the state. So it is a large number of people that continue to move into the program. We have hired 5 health plans. 4 of them have a statewide profile. One of them, Carolina Complete, does serve 3 of those regions, and that's why I have that beautiful map behind me. It's not just because it's North Carolina and it's colorful, but this is actually the map that we use to manage our Medicaid managed care program. As Libby said, well, and maybe you can't see underneath some of the cool branding, but we have Centene, we have WellCare, we have United, we have AmeriGroup and AmeriHealth, all working with us. And so these are the large Medicaid managed care organizations. There were some of the other ones that are on that list that Libby shared, but did not win a competitive bid. So we did the competitive bid back in 2018 and 19 and awarded in February of 19. So these are the common players. We have seen some consolidation, though admittedly Carolina Complete Health, which is a combination of a local provider group that is supported with the back office of Centene, and so they're a little different than WellCare, but there is a little bit of consolidation in our market, and that is something that we built in as part of our program, a recognition that this continued consolidation in the market might happen while we have our 5-year contract with these health plans. We wanted to plan for that, so there are financial consequences to the exiting and entering plans for this to assist us in the transition. Again, a recognition that would be disruptive to our beneficiaries, member experience that we're focused on, as well as provider access. So a lot of this, that consolidation is something that we had to plan for and had the benefit of being able to plan for because we were one of the last large states to go live with our managed care program. Do want to highlight of potential interest to your community is that in July of 21, we beat the state of Oregon with the first in the nation PCCM program to support the Eastern Band of Cherokee Indians. They have a goal of self-determination, and we wanted to support them in that. They have approximately 4,000 plus members who qualify for Medicaid, are federally recognized tribal members. They are on what we call the boundary in a number of counties out in Region 1 in the little green region, the light green region. And we did support them in their move. Originally, the Eastern Band did want to move to a full at-risk capitated managed care program. We suggested to them, though again, we did not make the decision for them. That was their own decision. But we did suggest to them that being at risk with a population of only 4,000 could push to them too much liability, too much risk, financial risk, if they had a very, because there is a lot of, you're trying to pool your risk, and 4,000 members is just, it's just very small, but they do hold that as a longer term goal and view moving through the PCCM program as part of their longer term vision of maturing their organization, maturing the way that they utilize federal funding to support their local goals. So that was something that we went live with on July 1st, as I said, and I have to just point it out, we beat Oregon by 3 hours because of the time change. So really proud of that, really proud of Oregon too, but it's tough being second. So here are an overview of some of the plans that we are working on or have implemented. So I've already mentioned the tribal option, and I have talked about, though didn't name it, the standard plan. So the standard plan is for, again, Libby pointed out, you know, your very traditional Medicaid managed care initial population, which tends to be your highest volume, your lowest cost beneficiaries. So these are your ABD population, your TANF, pregnant women and children population. So these are your traditional first steps into managed care. In some ways, it's a head scratcher because it's not necessarily where you're going to get your best cost savings as a program. But from an implementation standpoint, if you can't do this well, you definitely could not do the more complex populations well. And so I think that that's why a lot of states start here. We are in the process of implementing our behavioral health IDD tailored plan. And so while the standard plan was is approximately 1.7 million individuals, our behavioral health IDD population, which covers, as you can see, severe substance use, significant mental health, traumatic brain injury, and IDD individuals, this population is relatively small, and it's spread over 6 health plans, but it is approximately 188,000 individuals that will be transitioning on December 1st of this year. So we are I'd say knee deep, but it's probably neck deep in readiness, working with the health plans on end-to-end system testing, validating their network adequacy and their progress towards contracting with key providers. The key thing here for them is they used to manage the legacy behavioral health networks that I talked about, and they only managed behavioral health. We are now incorporating the physical health accountabilities and responsibilities within that tailored plan. So they have to learn really a very new skill, and that is that whole person care, and that requires them to make, pretty large cultural, business culture changes, thinking about that integrated care, really large system changes, now accounting for the prior authorizations that come with physical health, the necessary specialists that what you would have in your typical managed care program, but also the specialists that are going to serve the behavioral health IDD population. They're even unique and might not be present in our standard plan. And so we're taking a slightly different approach than other states. We have broken these plans up by really your physical and or behavioral health condition, as opposed to so we've literally broken the program out. So in order to qualify, you need to meet certain diagnosis codes or have utilized particular services to be in the behavioral health IDD plan or in the standard plan. I think that that's really the high-level overview of the program. Juanita, I'm open to any questions, directions, thoughts, feelings about where we could go from here. But that is the end of my presentation. I'll pause sharing. No, I don't know if I let go sharing or you. Oh, I'll stop the sharing.
I'll take care of that.
Thank you very much.
Appreciate it. Let me bring back Libby and also Ralph to get us started with questions. And just remind the audience, again, you can submit your questions for speakers in the chat feature. And you can also, if you want to ask a question directly, turn on your camera and raise your hand, and we'll call on you. But let's get started with Ralph. Ralph?
No, Jay, your presentation, I think, really emphasized the change, this idea of putting the MCOs between the state Medicaid agency and the individual, really emphasized that the role for the state changes dramatically in this system, and that you need people to design contracts, manage contracts, monitor, as opposed to being worried about paying for bills.
Correct.
The structure. So what I'm curious about, just the challenges for your staffing within the state agency. Did you need different kinds of people? How did you go about it? Because that's clearly a very different culture than the old, the previous Medicaid payment model.
Yeah, you're absolutely right. And so, just to, it has been a very large, though well embraced change in our organizational culture. So in some ways, and it's a gross oversimplification. And if Dave Richard, my Medicaid director, were here, he'd probably say it's not exactly right. But we really are moving from a place where we do the work, we're the doers, to the ones who oversee or manage the work, and that does require a much more mature organization. You need to really have a clear understanding of what you're trying to accomplish as an organization, to set out goals and understand how others will implement them and translate those goals into their actions. There's also a requirement that we develop the infrastructure, the data infrastructure, to align those goals with measurable expectations, and be able to capture the information necessary to monitor the health plans to be sure that they're actually meeting those goals. And a lot of it too is there's a little bit of trust and verify, right? So I don't want manually created. I need to create a oversight structure that can take in routine data, analyze that data, understand that data, understand too where that data may be lacking or blind to certain risks and issues. So you end up having to move from almost a regulatory, are we meeting the letter of the regulation, to an enterprise risk model where even if we meet the letter of the regulation, are there risks to our beneficiaries? Are there risks to our providers' financial models that may not be immediately obvious? And so it has been a large shift for our organization. We did not get additional staff. I mean, we got a small staff that were that the legislature did have some forethought and realized that we did need a specific team to help design this model. But generally, the Medicaid team did not get a large number of people. So we have been working on trying to teach our business leads how to think of the managed care companies as an extension of their own units, their own divisions, to effectuate their public policy and programmatic goals, and to do it with the framework that we have. And so it's been this balancing act, as it's almost been like, as somebody retires, we replace them with a new person that really more not understands, but can plug into the newer model. And so there's been this, we've had a commitment not to lay anybody off, and we have been transitioning, but it really requires a culture of oversight, a willingness to hold health plans accountable, and like I said, enterprise risk management. It's been a fascinating exercise for us. But yeah, you really hit on it, Ralph. I appreciate that.
Great. We have a question in chat from Sandra Heffern. She's asking, what in North Carolina, what kind of stakeholder process did you guys undertake to help move people towards the MCO model, to understand it, what their options and choices are? Is it strictly a matter of you select the MCOs and the MCOs kind of do the outreach and marketing aspect of it, or were there other efforts that were made directly by the state? And can you describe if there was any pushback from stakeholders in moving towards the MCO?
Yeah, I think I would say that Medicaid managed care was not a stakeholder-driven innovation. I do not think that stakeholders necessarily and generally sought a move to managed care. I think that there was a desire for change. That there were certain aspects of the previous program that did not work for beneficiaries, and so there was a great deal of, once the change was started, a great desire to become involved. And so, the stakeholder engagement was broad and deep, and varied over time. When the new administration came in, In 2017, they did a roadshow meeting with beneficiaries and providers out in the field for weeks, where the Secretary of the Department of Health and Human Services, as well as the Medicaid director and state staff, went out and held town halls, public forums for feedback. We went through a number kind of pre-Teams, pre-Zoom. We went through a number of initiatives where we published policy papers to the point where our stakeholder community begged us to stop, where we published policy papers. What were we trying to accomplish? Why were we trying to accomplish? We begged for feedback. We responded to that feedback. In fact, I still receive responses to that 2017 original policy paper that kind of was the cornerstone. We still respond to those inquiries based on the email address provided. We love that feedback. We hired and created an engagement office within the Medicaid agency. We made big investments in our communication arm. We created a webinar process and team. We worked very closely with associations and advocacy groups. And you know, I think where one aspect that we did struggle with, and we continue to struggle with quite openly, is reaching the individual beneficiary. We really we have a hard time getting to the individual in a way too that understands their experience so that we can understand whether it's an individual experience, whether it's a trend or a broader experience. Like how do you rationalize that feedback? So that is a point that we do struggle with. We remain focused on the member experience, like I said. And so we do not abdicate to the managed care organizations, their marketing program. They would like us to back off. So we review all of their marketing materials, and we will issue liquidated damages if they send things out to beneficiaries without getting our prior approval. And so we take a very, in some ways, heavy hand with them, though it does provide, it does apply a lot of pressure on us around that space. With open enrollment, and in fact, with open enrollment, there was a couple of things that we did. You know, one is we engaged with beneficiaries. We had really good relationships with them, and there was an issue that we started to identify during open enrollment that managed care companies, a feature of managed care is they're allowed to offer what they call value-added services. So these are services that at the expense of the managed care company, they can offer Medicaid beneficiaries above and beyond the covered benefits. And what we found were beneficiaries in some cases, and I don't want to sound paternalistic, but were making irrational choices. They were giving up housing for a cell phone. They were giving up access to certain services for I don't know what, you know, access to a Boys and Girls Club program. And it didn't, we were highly concerned that something wrong was happening. And so we used data to actually identify that problem. So we really knew, we were able to forecast how many beneficiaries we thought would change because of certain things. We saw that the numbers far exceeded it. We pulled back a bit. We met with our advocacy groups. We interviewed a number of beneficiaries to understand what was happening. And in fact, we pulled way back on that. We actually moved those beneficiaries back into the core program so that they didn't lose their benefits as we tried to sort out the program. We retrained our enrollment broker, and we went back through the process in a very intentional way to make sure that we addressed it. And we came back with a much smaller number of individuals who transitioned to the managed care program, and much more in line with what we forecast. And so it was that benefit of using data, having those community connections, being able to forecast out what you would expect should happen, and have the staff and contract leeway with our enrollment broker to actually make that pivot. But that was a key piece. So we have not given up on our beneficiaries. We remain really focused on their experience, and we need them to be healthy. We need them to be actively engaged in their community and in the workforce. And so that's been a primary goal of ours.
Great. All right. Thank you.
Yep.
You know, you both have spoken to the the impact of managed care and potential consolidation within the marketplace of both the MCOs, and I don't know how deep in the marketplace that might go, but in a state like Alaska, where our provider population is relatively thin, and of course we have a small population too, I would imagine that a rational response to some of this would be, a lot of reorganization and perhaps consolidation, and maybe even fewer providers in our state, or fewer arrangement. What I guess, Libby, I would suspect that you see from the survey what the sort of landscape looks like, if you're seeing consolidation in other states, and maybe what that looks like.
That data on managed care plans, that pie chart that I presented, that's from, we roll up CMS's, they put out an annual Medicaid managed care report, and they identify MCOs by parent firms. And so we roll that information up. We are not actually tracking necessarily consolidations in any way, but obviously it's been, across the media, clearly there's been Aetna CVS and Centene WellCare, have been a bunch of consolidation. But one thing I did want to highlight is there are a lot of, local Medicaid managed care plans, in addition to the national plans, that are very localized in a specific geographic area or county or just statewide. So though, that pie, and we're talking about North Carolina's Medicaid managed care plans, there are a lot of plans that are localized, and there are different types of plans. There are for-profit, publicly traded plans, there are nonprofit plans that are private, and government plans, there are provider-led plans. And so there are a lot of different types of provider plans in the space.
I would advise that that you simply plan for the possibility that it could happen. And to Libby's point, there are local organizations, and that was part of the legislature's effort to provide those regional, that CCH, Carolina Complete Health. They wanted to see non-national brands who would, from their perspective, help mitigate the risk of a large national brand entering and then leaving our market. But I think simply planning for it is probably a better alternative. You can't control it, you can't predict it. The cycle may fall outside of your procurement cycle, so it may happen, but it may not happen while you're running your program. But if you're planning for it and you realize that it could happen, then what everybody knows what their role will be and what will happen, and that creates greater predictability for providers who are making investments in their work, right? And that's really what I think a lot of our effort has been, is to provide as much transparency and clarity to the community so that they can make those calculated investment decisions on their own.
Great. All right, thank you. Sandra has a follow-up question. She's asking what percentage of commercial payers participate in the MCOs.
What
Sandra, do you want to come on and provide clarification?
She sounds like one of my legislators.
Yeah, I just wanted to, thanks, Juanetta. I just wanted to see if, and Libby, you may be the best to answer this, is just looking at, I know that in North Carolina, we were focused on Medicaid, but just wondering, what's the commercial marketplace look like? Are they participating in, MCO type models throughout the country?
Yeah, I think, these big national plans, there's a lot of commercial participation. I think after Medicaid expansion was introduced, you saw also plans that weren't participating in other markets start participating in marketplace, who were just participating in MCO to provide some continuity. But I don't have exact, stats on the percent of all commercial plans that participate in Medicaid.
Can I ask a follow-up, Libby?
Yeah, go ahead.
In terms of, I think the numbers are that, like, nationally, 40% of Medicaid are in MCOs, and something in the high 60s of Medicare are in some sort of Advantage plan. Are those, A, are those numbers right? And B, sort of what's the, how do those interact? And I think Sandra's point was getting to, how is it interacting with managed care in the private commercial sector? How are those big three, the private, Medicare, and Medicaid, in terms of the move to managed care? How are they moving together? Are they moving separately? Is one of them the first mover?
So I'm not sure about Medicare Advantage, but the stat in the Medicaid world is that I think it's, over 2/3 of beneficiaries. I think the latest data we had were from 2019. It's over 50 million beneficiaries in Medicaid that are in comprehensive MCOs, and about half, or just over half, I think 63% of Medicaid enrollment is in firms that are parent firms that have MCOs in multiple states. Of those, I just don't have stats off the top of my head about commercial.
Well, I think the question it's in our minds is how we're talking about integrating care, but in fact, people move from the commercial market to Medicaid, but maybe they will after the pandemic. As you mentioned, there's some inflexibility right now. When someone retires, they may move from commercial to Medicare. How is that? Is it a different model of managed care that's emerging in Medicaid, in Medicare, and in the private sector? Or is it something that someone who moves between these systems is going to recognize?
I think that there's, a lot of attention on the marketplace Medicaid lines of business, especially since Medicaid expansion. And I think as a state, you could, evaluate and make decisions about the players in your state and what lines of business they have and what opportunities that presents to the beneficiaries who may be in Medicaid, but then maybe their income grows and they are out of Medicaid, but may not have employer-sponsored insurance. And so I presume you could kind of evaluate the market in Alaska and the types of plans and lines of business available.
In North Carolina, we have Blue Cross Blue Shield of North Carolina, which is in the commercial market. We have United, which is in the commercial market. WellCare is not. Centene is, depending on their version, they might be. We focused on marketplace integration, as Libby just said. We are seeing some vertical integration, like an organization like United is trying to, I think, play up and down the Medicaid, the exchange, commercial, Medicare Advantage. But that's more anecdotal. AmeriHealth, Caritas is obviously not. So what we've seen is there are some organizations that see moving into Medicaid managed care as a strategic move. Like I think United came in thinking that it's a strategic move so that they can claim the whole the whole stack of beneficiaries. I think what's been interesting is watching the organizations that have a commercial footprint as compared to the organizations that don't have a commercial footprint in their provider contracting. And what we have seen is we had to create very specific rules where we did not want our network adequacy requirements that require managed care companies and, for example, large hospital system to engage in contracting or really encourage it from bleeding over into the commercial market and compelling otherwise uninterested parties into contracting on commercial. So we created some boundaries and separation in that space, but we still see bleed over. So for example, we have a very large hospital here in the Raleigh area, the Business Triangle area, that is having tremendous problems with one of our health plans on the commercial market and won't even talk to them on the Medicaid side. So the consequence to Medicaid is that by having this commercial player, we actually lose, we have this big gap, but our only regulatory or contractual lever on them is to hold them accountable under network adequacy. And in fact, they're actually technically adequate under our network adequacy thing. So now we're trying to figure out, well, do we have a problem with this? I mean, we have a problem with the fact that we've been dragged into this fight, and it's almost politicized a commercial dispute, which would normally not be politicized or be, you know, it's dragged us into some fights that we didn't want to be in. But it's, look, this, again, it kind of becomes the feature. It becomes your local flavor. Not that I'm excited by that flavor, but it's rocky road. How about that?
And I can add too, as Jay was talking to, I think, you know, nationally, probably about half of plans are Medicaid dominant or Medicaid only. So enrolling 75% or more Medicaid, just Medicaid beneficiaries, or are just Medicaid only plans. I would also note that I think there's been a lot of attention at the federal level in terms of regulations that govern Medicaid managed care plans to align some requirements between markets, MLR requirements,
Yep.
And other requirements across markets. So I would just mention that's kind of in the background.
But I don't know that they would fully recognize. They might recognize components of the network, the provider network. If a beneficiary, from a beneficiary perspective, if I'm a United beneficiary, I might, and in Medicaid, and I'm no longer in Medicaid and move into the commercial market, some of the providers are going to be in network, some are not, because they're Medicaid specific, or Medicaid emphasized that you need to have these providers in your network, and the commercial doesn't care. I mean, care is not the right word, but we'll just go with that. The other is probably the care management component too. We are very prescriptive about, you know, the assessments you need to make, the fact that social determinants are an offering and an intentional offering. We would expect you to offer them through care management. I think that's a part that a beneficiary may be surprised that they don't have access to care management as they knew it, because it's just the commercial market. Just I'm not aware of it. At least I haven't experienced it personally. I'm not aware of really robust care management in the commercial market.
All right, we have a comment in chat from Dave Morgan, who says that without reform to the Certificate of Need program and the Hospital Rate Review Commission, that the managed care model would not probably be effective in terms of containing costs or improving access for quality, improving access and quality. So thanks, Dave, for that comment. I'll just, don't see any other questions coming in. I'll just make one last call. Anybody who wants to ask a question can turn on your camera, raise your hand, or put it in chat. And I guess one question I would go back to you with, Jay, is in terms of, again, the rural population and what you're seeing, has there been, I mean, in terms of Alaska, you know, the geography is a little bit challenging to understand, but the population is even more concentrated, and then vast swaths of land and very small rural communities, and the challenges of doing just the transition, the rollout, and looking at how it's changing offerings to those rural residents. Are there any particular lessons learned? You've mentioned the Eastern Cherokee Band and their MCO. Are there other things that you're seeing in rural areas in North Carolina that might be instructive for Alaska?
Yeah, I think, again, going back to the concept of network adequacy, it's a crude tool. I would not use it as the best way of measuring whether or not health plans have sufficient providers, or that through a, you know, continued liquidated damages or holding the health plans accountable, that suddenly they will be able to, you know, get a podiatrist in a small rural, you know, area, right? I just don't think that that's necessarily a realistic tool. I think that what we have seen in our rural areas is when your non-emergency transportation system does not function consistently, that's probably one of the bigger limitations on access than whether or not you have a provider in a particular location. Because if the beneficiary can't get there, then they doesn't really matter. And so we've been somewhat caught off guard by the weakness of the managed care companies themselves without significant continued involvement by the state around non-emergency transportation. I think, I think an interesting dimension is telehealth, and how does that interact with really your health goals, and whether or not it works for some things, it does not work for others. I would not recommend telehealth for behavioral health testing for a child 0 to 3. I don't think that's going to work, though we have had local advocates push for that. But so I think you've got that. I think the other is a huge, I think if we could have done it again, it would have been to be more embedded as a state agency before we even designed Medicaid managed care, and really had incredibly detailed conversations about expectations. I'm going to call it best practices, but it's more like what's worked in your community, and then looked at ways to develop innovations. So I think that what's going to have to happen is, if that's really important from a state agency perspective, and I don't want to try to box the Alaskan Medicaid program in, but I think you need to think about, how do you fund that? How do you hold the managed care companies directly accountable or peripherally accountable? How do you create incentive pools that allow for the experimentation and testing of new ideas that you really can't do in a fee-for-service program, but you can do under the guise of it's a contract. It's I don't even need a waiver in some cases. So I think that there's a better opportunity under managed care to test new ideas, but I think that it's a tough thing to crack, and really you've been very generous. You've called it rural. It's really territorial. Isn't that the technical definition? Or tundra? I mean, it's very different. I think even the issues that you would be dealing with in Alaska, but I think that really gives yourself an opportunity to say, we're looking for innovation here. We're looking for, we will reward in ways that you can't imagine, a change in the health or the impact on quality. Like, you could really offer almost a moonshot pool of money or flexibilities to managed care companies to really try to innovate. That's off the cuff recommendation or thoughts.
Right. Your rural and our rural are something quite different.
Yes. Yeah, we still have 10,000 people in our small, tiny counties. So yes, and it's also the distances. I think the distances are as much of the issue as the size, I think. So
well,
yeah,
we've been very fortunate. We were talking earlier with the vaccine rollout, that we've been very fortunate in Alaska in that we do have a high density of Alaska Native population, military and veterans, and combined those healthcare systems really moved us forward very rapidly as a state, just because of the density of that population. Moved our numbers up very quickly. But one of the key principles that the steering committee for the group had was that any recommendations would hold harmless the other systems, that those things are, that diversity and those systems have been a strength within our collective healthcare system.
Yeah, and so if that's important to you, you need to make sure that you have really strong contract language, right? And so there are certain provider types in North Carolina, though it's a capital P political, which ones they are, who are guaranteed a certain rate. And Libby touched on this before, right? Where do you want to see your innovation? You may not want to see your innovation in some of these, far away, or the unintended consequence of suddenly taking a third of your population in a certain area and having them redirect to a different service provider or different system could have unintended consequences that, if really are important to you, you want to carefully craft your contract with the managed care companies in a way that, again, incentivizes them for following your public policy goals, which is to maintain a current system in some areas. You want to see innovation in others, but to really, you need to align your money and your sticks and carrots so that if they fail that public policy goal, that there's severe consequences, and if they meet it, there are unfathomable wealth it can be conferred on them. But that's the only their fear of being fired and their desire for a good profit is really the prime motivators. And so in our contract, we have very clear liquidated damages. We have very clear escalators, and those escalators in the worst case scenarios include being able to fire the CEO. Like firing the health plan, that's a dramatic moment, but putting that CEO and writing a letter saying, we've been trying to work on this issue for a while and you're not making any move, and we're going to ask your corporate partner to find a new CEO. It's a powerful motivator. And, look, we have no intention of using it, but it's that carrot and stick. So.
Well, I would be remiss if I didn't make this point. Particularly the Alaska Native healthcare system is incredibly innovative in Alaska.
They are.
And in part driven by our geography and our scale and the distances.
Yep.
And we're very early adopters of telehealth. South Central Foundation here in Alaska has some incredible care. Their NUCA care system is quite effective and incredible. So yeah, it's challenging to think about how to modify the system in the context of having those strengths that already exist within our healthcare
Just
system.
write really clear contract language.
Yeah.
That's the key. Very
Okay.
clear contract language to protect the things that are important to you, and to allow directed innovation in the areas that you'd like to see the innovations.
Absolutely.
And very familiar, the EBCI is following Alaska and the work that the native Alaskans, the work that they're doing. So the EBCI follows it closely.
Yeah, and I think likewise too, looking at what they're.
We should get them together.
Yeah. Just a couple of quick things then. I want to bring Ward Hurlbert in. He had a couple of comments.
Yeah, can you hear me, Wanda?
Yes.
Are you there? Are you there, Ward? Did you call in?
Can you hear?
Yes.
Yeah. Okay, go ahead.
Yeah. As the one said, I'm Ward Hurlbert, and I was with the state for a few years, serving as Chief Medical Officer and Director of Public Health. And in that role, I chaired the Alaska State Healthcare Commission.
Yeah.
There have been more than one healthcare commission over the years. This one had started. I came on during the Parnell administration, which was 2 administrations ago now for those of you out of state. And one of our recommendations was to have Medicaid managed care, which went to both the governor's office and to the legislature. And those recommendations were accepted and progress was started. I was in a political position, and so when Governor Walker was elected, I was thanked for my service, but the service ended because I've been with the previous administration. But the progress continued on that. And toward the latter part of Governor Walker's administration, there was an RFP let, and it got so far that United was identified as United Healthcare as virtually certainly the successful bidder for that contract. And United believed that enough to the extent that they went ahead and hired in-state staff, I think 7 or 8 in-state staff, and brought their systems in. Spent several $million doing that. And I was hired as a CMO. I've normally been CMO with Molina with a large Medicaid managed care program in Washington State. Our CEO and others of the staff had a lot of very collaborative meetings with the state Medicaid program, with the tribal health system, because as we pointed out, that's so critical in our state, with providers and with others, and things seem to be on track. And then again, we had another election, and Governor Dunleavy was elected, and in the initial few months, things continued to progress. But Governor Dunleavy's administration decided they wanted to go a different direction. I don't think that was specific. It was probably to pull back it, and so that contract was stopped. But we're not totally naive with no history in Alaska. We got almost up to the finish line of having managed care, and I know a number of folks on the call are aware of that, but I suspect you all aren't from out of state, and several folks here. So there was interest. There was a lot of work done in the past, generally on all sides. Those that I mentioned very collaboratively, which most of the time is one of the really nice things about Alaska. We're small enough that people do work together well. Anyway, I just didn't want to bring up that part of the background.
Okay, well, thank you so much for that, Ward. Appreciate it.
Thank you.
Ralph, did you have something?
Yeah, I'm very interested in this question of institutional innovation, because that's clearly underlying we're really changing what everybody does in terms. But in terms of the providers, it strikes me these providers are coming from 2 different directions. One are what we might think of as insurance companies, broadly defined. And the other one is groups of providers or people that are already, healthcare systems like hospitals that have clinics associated with them. And of course, the healthcare systems don't have experience with risk management, and the insurance companies don't have experience actually running clinics and that sort of thing. What kind of, are we headed towards some sort of single model? Or are we continuing to have multiple different kinds of providers? What are the benefits, or what are the institutional benefits that each of those 2 sides bring to this new managed care environment?
Libby?
Yeah, I don't know that I have too much to offer on this. I mean, I know these different models exist and states make different decisions. In terms of like the literature and the research, I think it's only in more recent years. I described in my presentation that there's some real challenges to evaluating these models and evaluating impact on cost, access, and quality. And I think something that has been identified as a major deficiency in the literature, and I think California had a big study come out not too long ago, looking at impact of their managed care plans. They have an interesting system, but they have government plans, commercial plans, kind of every flavor. But there's a real scarcity of literature on, what is the performance by type of, plan and organization. I think there might be a little bit of research out there. California, as I mentioned, was looking at performance on quality measures, et cetera. And I think there were some surprising findings in that report in terms of performance and expectations. So I'll send a link to that report if I can get my hands on it. But yeah, that's an area I think there's definitely a need for more research.
Yeah, and I would add that, the whole question of, well, at its most basic, does managed care work? And then when you ask work, what are you trying to accomplish, right? And so a lot of people will define that work in a way that shows success. And I think what's interesting, and this goes back to the cultural question, Ralph, that you asked at the beginning, or the what do states have to do differently? We've made large investments in ourselves, and in fact, we probably know our business better than we did 2 years ago, 4 years ago, 6 years ago, because we've had to really think about what do we want these other organizations to do for us. And you know, in the old days, in the 80s, it was like, oh, thank God we're out of this business. And now I think there's a recognition that no, you can't abdicate to the managed care companies. You don't get the public policy goals, you don't reach them if you don't stay involved. Though managed care companies have asked us to please stop staying involved, because we stay involved. But I think the other part though is that I think that this is also, it goes to COVID, and maybe it's just timing here in North Carolina. We have invested dramatically in our data infrastructure, right? So we capture, in my old organization in Missouri, we really struggled with encounter data from managed care companies. In North Carolina, our old those LME MCOs, the ones that are being converted into tailored plans, we struggled to capture that encounter data. So in many ways, we didn't have a full, complete, integrated picture of what was happening in the managed care companies. That's been one of our key priorities, the encounter data. So we are already, within 3 months, we had 98% acceptance rate of encounter data. So we were immediately getting a view of what the managed care companies were doing or not doing. We take not only their paid claims, we take their denied claims. So we have an incredible understanding of, or have the potential for an incredible understanding. I actually need to hire staff to do all that analysis, but we have an incredible opportunity to analyze that. And so I think that you're likely to see better information coming out about whether these models work and how do they work. And when do they work for which populations? But yeah, it is a little murky right now. So right now we're kind of in a and we're transitional. So we're probably more in a do no harm. Let's not go backwards kind of mode, as opposed to, you know, whether all of this will work, quote unquote.
So Jay, just at an anecdotal level, you obviously deal with some firms that are whose names, or at least are insurance companies. They may well be setting up clinics and so forth. And you certainly deal with entities that started out as provider networks of one kind or another. Mm-hmm. Do they come to the table with different worldviews? Do they present you with different sorts of challenges when you're dealing with those two different types of organizations?
So every 2 weeks we meet with the hospital association. Healthcare Association, the hospital association, to go over how they would like us to change the program to be better for hospitals. You know, we also had a conversation recently with managed care companies, which asked us to please get out of the business of protecting providers from the program called managed care, because they've got it. And you know, and our constituents say, like, they're not getting paid enough, or they're, you know, they have these unrealistic administrative burdens that they have to go through. So absolutely, they have different worldviews, and there's a lot of you know, why are you doing this to us? And we get it from both sides. So you know, we're either doing it perfectly, we've hit the sweet spot, or, you know, really they just want it different. So absolutely, they bring in different worldviews, but it goes to that other ecosystem question, which is, how does this all affect just generally health in North Carolina? Are we disrupting the commercial markets? Are we, you know, we've got large military bases in North Carolina as well. Like, so how does this all interplay? And I think that's what's interesting, because now they're getting merged, but now we probably have a better opportunity now that they're playing on all the levels now. At some, you know, Medicaid, exchange, commercial, Medicare Advantage. I mean, there are others, but now that they're playing on all of those levels, we're seeing more system-wide conversations, like, what is the impact on hospitals? And we have a complete view, even as a government agency, or nearly complete view of what our policies and how that affects the ecosystem, but also how the ecosystem affects some of our expected outcomes as well.
Thank you.
Yep.
I'm just going to roll up to that point. Sandra Heffern also was asking, are you seeing providers leave or not participate in the MCO?
Yes.
Are they sort of creating hybrid separate markets?
They don't have access. That becomes the issue for providers, right? Which is a terrible thing from a Medicaid perspective, because we fight so hard because we don't pay well. We fight so hard to get providers in. We are seeing providers leave. Now it's probably not as many as every one of them though is bad, but we definitely are seeing them. And then I think what we're trying to track down too is who, because to lose another hospitalist, I don't know, but to lose a specialty provider that only serves IDD individuals, that's devastating. That's devastating to the community and the individuals that get served, but it's devastating to that community and that specific population. So it's not just the number, it's which service type. And Medicaid offers services that honestly nobody else reimburses for. And if we lose those individuals, especially in the behavioral health space, it's devastating.
Are you seeing anything from the other states as far as lack of provider participation?
Sorry, you cut out just at the beginning of that. Were you asking from a national?
Yeah. Mm-hmm.
I think, that's not something that we track. I mean, managed care has been so entrenched for so long in so many states. But I think recent transitions where there was a lot of negative media attention in states like Iowa, you not only had probably managed care plans leaving after they rolled out because of what they said were inadequate capitation rates and other issues, but you had a lot of backlash from providers about administrative burdens and other issues trying to move beneficiaries through prior authorization and prompt payment policies, et cetera. And I think a lot of criticism in Iowa was the speed at which they went from having the legislation that was the catalyst for managed care. And then I think within a year, they were contracting and had moved 80% of their beneficiaries.
Yeah, we actually looked at Iowa as a model of and I don't think Iowa would care if I said it, of what not to do, right? Well, they might, but I just said it. So they had a lot. We learned a lot of lessons from Iowa, and in fact, we spent a lot of energy. We continue to spend a lot of energy on provider and health plan readiness because of the speed. But again, in Iowa, it was specifics. Specialty types and provider types that left and left for good. And we had a similar event in North Carolina with some of our behavioral health providers left and have never come back. And it stings for a short period, and the shadow is long when those providers leave. They have no need. They replace the financial consequences of leaving, and then Medicaid really can't compete with that. So it's definitely a challenge and a risk for states and providers.
And particularly, I would say during COVID and the pandemic, where we're just seeing workforce challenges generally as well.
Yeah. Yes.
Well,
But that feels a little different because it's not us causing it, but it's us having to solve it.
Right.
Yeah. But yeah, we are definitely having workforce issues all over, especially in nursing home. And go ahead.
Yeah, I was just going to say, it just the loss of providers, having born and raised here in Alaska, and when I was a child, medical tourism was really the way to get care. I mean, other than the sniffles or something basic with primary care, most everything else you traveled outside for medical care, and in some respects it feels like there's a strain of that already happening in Alaska, even without some major transformation to the payment model. So whatever is driving that, whether it's workforce or other market issues, I mean, certainly basic economy issues here are also a driver. But at any rate, folks, we are over time. This has been, I think, a very productive conversation. You've given us a lot of food for thought. So I'm going to go back to Ralph and for any closing comments. Ralph?
Again, thank you very much, Jay and Libby. This, as Lynette just said, this has been really, really helpful to get both the national and the specific implementation and perspective on it. I really appreciate your time. I did want to just remind folks that the next program in this series is a week from today, and it's talking about the Alaska Health Tie Program. And we look forward to having you. And Juanetta just put in the chat, again, the registration link. So thank you very much for joining us today. And we look forward to seeing some of you again next week.
Thanks. Take care.
Thank you.